Baburam Govind, Dr. Baburam Govind, please.
Good morning to all. Today I am going to present a clinical case where it's a story of an intraorbital foreign body. It's a case of 45-year-old male patient who works as an accountant, presented with complaints of double vision and limitation of movements of left eye for a duration of 1 month. Coming to history of trauma to right eye lower lid on 5th of December 2023 while he was traveling in an open trailer of a truck where his head collided with a tree branch and a twig punctured into his right eye lower lid near to the nose. He was taken to a nearby hospital and primary management was done where the patient gave a history that the foreign body was removed and he was referred to the medical college. On arrival, his visual acuity was 6/6 and ocular movements were full and free in all gazes with normal pupillary reaction, digital tension and AC. X-ray face and CT brain was done which was reported as normal and he was posted on OT for the next day for wound exploration and there was no foreign body found and hence laceration was sutured and canalicular injury was repaired and on post-operative day patient was asymptomatic and discharged. He came with complaint of double vision and limitation of movements 1 month after on January 2024, which was more on looking down and left. There is no history of periorbital swelling in the left eye, diminution of vision, fever, headache, vomiting or painful ocular movements. General examination and systemic examinations were unremarkable with normal head posture, forehead, eyebrows and hair facial symmetry was maintained. We could appreciate an infected draining sinus over the medial aspect of right eye lower lid and HBCR was central. His best corrected visual acuity of both eye was 6/6 with a correction of plus 0.5 diopter cylindrical at an axis of 180 degree and a near add of plus 1 provided him a vision of N6 and NCT was 20 and 18 with pupils being normal and color and contrast sensitivity being normal. Ocular movements revealed a limitation of movement in superior levovision and on inferior gaze. And as depicted in 9-gaze photo also, we can appreciate a limitation of movements. A strabismogram was done which revealed a squint of 30 prism diopter in left hypotropia and a diplopia charting where the diplopia was more in inferior gaze and on levoversions. A Park 3 step was done and it revealed a involvement of left inferior rectus. A force detection test was done and we were unable to move the eye towards down and out, the left eye. Coming to the investigation, we did a review of CT where they have repeated a linear artifact in the left eye orbit. Hence, we moved to a MRI brain, which again revealed an linear artifact which was almost which was almost 4.9 to 0.5 centimeter and with impingement of left inferior rectus, medial rectus and inferior oblique. Hence a diagnosis of elongated wooden body with the following measurements: puncturing the right eye lower lid, entering into the left orbit, causing impingement of left medial rectus, inferior rectus and inferior oblique was made. Management: he underwent nasal endoscopic guided foreign body removal through the entry wound under GA and a foreign body of the following measures were removed. On post-operative day 1, he was having a good vision of 6/6 with the near add and pupillary reaction were normal and peculiarly the ocular movements were normal in both eyes. Thank you.
I think it's very well managed, extremely well managed.
Thank you, sir.
Yeah. ENT surgeon did it? Was it done by the ENT surgeon?
No, sir. It was removed by the ophthalmic surgeon itself.
And under endoscopic guidance?
Yes, sir.
Wow.
Under endoscopic guidance, through the entry wound itself, okay. Our consultant had removed the foreign body.
Very well done. Very well done.
Okay, regarding 9-gaze photograph, what happened to dextro elevation and levo elevation pictures?
Sorry, ma'am. It was taken just before the patient was shifting into the OT. It was in a hurry, so I couldn't take the 2 photos. At the time of injury, there was imaging done, sir, just as you told before. It was not picked up in the CT actually. Actually, we could have gone for an B scan also because it was like if you haven't found something on CT, the imaging that as an ophthalmologist, we could go for B scan also. But at that time, the patient also gave the history that the foreign body was removed from the outside hospital in pieces actually. So everyone was suspecting it's only a tract that was found at the acute stage. But he came back later. Since we were also lucky, the patient was also cooperative. He came back after 1 month to our institution itself.
Only thing is that you have to do a follow-on MRI after the inflammation subsides, because in wooden foreign body, conventionally it breaks into pieces. Even
Okay,
smaller,
sir.
deeper pieces could still be there, although you have removed the main wooden.
Okay, sir. The later follow-up, the patient was actually normal.
Yes,
We will-
symptoms-wise they will be normal, but like the child presented many
Yes,
years
sir.
later, they may come back with an extruding small foreign body or
Granuloma
granuloma
formation
formation.
can be
So always a good idea to, once the inflammation subsides, maybe 3 or 4 months later, you can repeat an MRI and then see if there is anything residual at all.
Sure, sir. We will forward to that. Okay. Thank you, sir. Thank you very much.